Good afternoon, guys. This is Dr. Mo here. Today I will be discussing one of the most important branches, which is gynecology and sexually transmitted infection or sexually transmitted disease. Okay? In your exam, in PLAB2 exam, you must have a station gynecology and or a station of sexually transmitted infection or sexually transmitted disease. Okay. Before I go and I start with the branch, I would like you to know that my structure stays the same. However, I will only add one thing to the regular medicine structure in order to fit the gynecology structure, which is our medicine structure was P1, P2, P3, maftosa. This is our medicine structure. P1, P2, P3, maftosa. Our medicine structure, P1 was the presenting complaint. How can I help you? Then the patient will give you a complaint. Quick recap. Tell me more about it. Then, after tell me more, you ask the questions, which will be either Socrates or Odipara. Then, concern, main concern. Then, differentials. Then, flows. P2, past history of presenting complaint and past medical conditions. P3, lifestyle. If you remember, lifestyle used to be DESA plus or minus sexual history, and IV drug abuse. Yeah. So in gynecology stations, I will focus on this: sexual history plus or minus sexual history and IV drug abuse. So sexual history and IV drug abuse is a must in all gynecology station. Okay, so Dr. Mo, the structure is P1, P2, P3, maftosa stays the same, yes. But you said there is a small modification, which will be P4, and I will put it in red, P4. So P4, I will add it, which is 4 P's or P4, which is period, pregnancy, pap smear, and pills. Pap smear and pills. So, period, pregnancy, pap smear, and pills. So, that's P4, and that's 4 words. Period, pregnancy, pap smear, pills. So now, Dr. Mo, what is the difference between medicine structure and the gynecology structure? In medicine structure, I said in P3, DESA, plus or minus, sexual history and IV drug abuse. So sexual history, IV drug abuse here will be a must in any female. Plus P4, which I added now to our structure, which is period, pregnancy, pap smear, pills. And I will tell you now. So this is the potent things in the structure. So don't forget 2 things now: sexual history and P4. All right. Dr. Mo, you said period. How do I ask about the period? Ask about the last menstrual period? Any bleeding in between? Is it heavy? Is it regular? That's for the period. So ask about the period, 4 questions. After you ask about the period, what else? Pills, and pregnancy. When you ask about pregnancy, so by any chance you're pregnant, that's it. And from the period, if it's late, you can suspect a pregnancy. Then the third is pap smear. Only if the female is more than 25 years old, you can ask about it. Are you up to date with the pap smear or the smear test? Then pills, if she's sexually active, try to ask about method of contraception. Are you in any contraception, or are you using the pill to prevent pregnancy? So that's the pill. So 4 questions in P4 plus sexual history. In sexual history, it's very important to ask about sexual history in details. How? Sexual history in details. Are you sexually active? Then the second question, do you practice safe sex? By that, I mean, do you use condom? Okay? Do you have a stable partner? And if she said no, ask about other partners. And when you ask about partners, you need partners for 6 months if you're suspecting a case of STI. So only you ask within 6 months, period. Okay. And you ask more questions in sexual history, like the preference, like if they have an NL6, if it's an HIV case, and IV drug abuse is a question as well. Okay, so that's the potent thing in gynecology: sexual history, IV drug abuse, P4, and everything else stays the same. However, I want you to focus that I will bring P4 early, and I will show you when I start the stations how I bring P4 early. P4 early. Early, why? Because a female might come to you with pain in the abdomen and you are suspecting ectopic, so then you will bring P4 early, which is period, pregnancy, pills early. So P4 in gynecology will be your P1 in most cases. All right. So, and one thing I want to add, if you have a female who's coming with discharge from the front passage, that's her presenting complaint, do not forget to explore discharge with using the term track. So whenever there is a female who's coming with presenting complaint of discharge, I will use track. What is track? Track is the term that I will use to explore the presenting complaint if it is discharge. T for timing, when. R for, and T for timing, and it could be for trauma as well. Okay, R, and what I mean by trauma is procedure. So T for timing and trauma. And trauma could be for procedure if the female had any procedure to the front passage. R for relation, is it related to anything specific in particular? A, amount. C, color, and you can say nature, and you can say does it have any blood in it. So track for discharge if the presenting complaint is discharge. Okay, so I will take all of this now and I will start discussing the cases one by one, and as I mentioned to you, I will always follow the structure, which is P1, P2, P3, P4, maftosa. I would like to remind you, if the presenting complaint is related to period, pregnancy, sexual history, that will come as P1. That will come early. Number one. I would like to remind you, how many differentials should we take, Dr. Mo? Maximum 4. I would like to remind, so maximum 4 differential. Go back to day 1 in the medicine, and do you remember? In differentials, I need 4 differentials. And I would like to remind you that your history should be short focused. What do you mean, Dr. Mo? In P3, if a female is coming with discharge, you don't need diet, you don't need exercise, but you need smoking and alcohol, because the smoking is a risk factor for cancer, cervical cancer, for example. So you don't need diet, you don't need exercise. So I'd like to remind you, be focused, be relevant, short history, only 4 differentials, and diet is not important, exercise is not important if it's not related to the case. So the first case I will start with ectopic pregnancy. And ectopic pregnancy, you can write down the stem. You are an FY2 doctor in the Obs and Gynae department. Emily, 18 years old, presented to the hospital complaining of left iliac fossa pain, or it could be right iliac fossa pain, whatever. The patient has come with 7 weeks amenorrhea. She has not had period for 7 weeks. Pregnancy test was done and it is positive. Talk to the patient, take relevant history, and manage the patient. All right. So, what is the presenting complaint? Abdominal pain. So this is my structure: P1, P2, P3, P4, maftosa. Okay. So my presenting complaint is abdominal pain. Okay. So what you need to do is, I'm really sorry about that. Are you comfortable talking to me? You know, the start of any station, sympathy and empathy for the pain. Then, can you please tell me more about it? She will tell you about the pain. What do you need in the pain? Socrates. Don't forget pain, Socrates. After exploring the pain, apart from the pain, anything else? So she will tell you, doctor, late period, late period. So if you remember, the second presenting complaint is late period. So as if she brought P4, because you remember, P4 was period, pregnancy, pap smear, pill. So she brought the period early. She brought it, she said late period. So P4 will come early. As I told you in the first 10 minutes that P4 can come early. So explore about the period. When was the last period? Number one, doctor, it was 7 weeks ago. Then, if it's 7 weeks ago, ask her the one before that to know if it's late or not. Yes, 7 is late, but just ask about the period. Late. Was it irregular before this time or not? Because maybe she's that kind of a patient who has irregular period anyway. So explore about the period. Okay, before this time, is it always late? How often do you have it? Because maybe it's 7 weeks, but that's irregular for her. Maybe it's 7 weeks and that's normal for her because it's irregular anyway. So explore the period. And as I told you, it's P4, period, pregnancy, pap smear, pill. So when you bring it early, I will also ask about pregnancy. By any chance you're pregnant? Yes, doctor, or whatever. Then when you ask about the abdo pain and the period, she will give you the hint of, yes, she is sexually active. So you remember, P3, I said P3 is DESA, plus or minus sexual history and IV drug abuse. So sexual history will come early. So I will ask must about sexual history. Are you sexually active? Do you practice safe sex? By that I mean use the condom. Okay? When was the last time you had unprotected sex? Sexual history. So after exploring the pain, period, sexual history, then you need, as I told you from day one, in day one, I told you, we are here not only to diagnose, but also to find the risk factor and the complication for the case. The risk factor and the complication. So if I ask about the abdo pain and the period is late sexual history, and I'm suspecting ectopic, don't forget to ask about the risk factors. The risk factors for ectopic as well as complications for ectopic. Okay, Dr. Mo, what are the risk factors for ectopic? The risk factor for ectopic 3P plus 2I. 3 P's and 2I, yes, risk factor. The causes for ectopic. So not only I want to tell her you have ectopic, I'm suspecting ectopic, but I want to know the risk factor. 3 P's, 2I. 3 P's. What are the 3 P's? Any previous previous ectopic. Any previous procedure. So previous ectopic, previous procedure, and PID. Okay? 3 P's. 2I. IUD and medication that they use it for fertility. So infertility medication and IUD. These are risk factors for ectopic. Plus complication. If a patient is coming with ectopic, can be complicated. What are the complications of ectopic? Rupture ectopic. So I will ask her about dizzy. If she feels dizzy, any dizziness, lightheadedness, or do you feel that you are about to faint? Okay? And always ask about bleeding from the front passage. Alright, so now I have asked the presenting complaints, the risk factor complications for my condition, which is ectopic, that I'm suspecting. So don't forget to ask some DDs, because we said P1 presenting complaints, and because I'm suspecting ectopic, ask about the risk factor and the complication, because I said we are not only here to diagnose, but we are also here to find the reason why she's having the condition and the complication. So I need few differentials. How many maximum? 3. Maximum 3 differentials. For what? For the abdo pain. Vomiting, diarrhea, any vomiting, any diarrhea, any fever. So few differentials for abdo pain. Any pain while passing urine, and that's it, maximum. So GIT symptoms, urine symptoms, and that's it. Pain while passing urine, change in the smell or the color of urine, blood while passing urine, and you can ask about vomiting, diarrhea, and that's it. Alright, after that, what's your main worry? What's your main concern? As we know, after that P2, have you had similar pain before? Any medical condition? Quickly. After that P3. So P2 is done. P3 is DESA. Diet is not important. Exercise is not important. You can ask about smoking and alcohol. Yes. But very important, the sexual history, which you asked early. P4 already asked early. And then maftosa. medications, are you on any medications, any allergy to anything, family history. Okay, travel you don't need, occupation you don't need, social, yes you need, because she's 18 years old, who do you live with, and be careful because if she's less than 18, if she's 14, with abdominal pain, you need to ask about the partner because the age of the partner must be asked if she is less than 16. That's it. And the last A is anything else you'd like me to say. So I walked you through now how to use my structure in the ectopic, because the following cases, I'm just gonna go ahead with the case. But that's what we're gonna do. P1, P2, P3 maftosa, P4 maftosa. P4 can come early if the presenting complaint is one of the P4. P3, diet is not important, exercise is not important, smoking alcohol important, sexual history all the time important, and that's it. Differentials maximum 3. And when you are diagnosing a condition, you need to think of any risk factors or any complication of the condition. All right. So that's ectopic. So what are the symptoms? Now I'm gonna walk you through the positive symptoms. Number 1, missed period, signs of pregnancy, tummy pain on one side, bleeding from the front passage, and that pain could refer to the tip of the shoulder. Okay, red flags, as we said, dizziness, looking pale, about to faint. Okay, on examination, right iliac fossa tenderness, and be careful because this case sometimes it comes as combined. Combined means sometimes they ask you to examine the abdomen. Okay, so in that case, you will examine the abdomen and you'll be giving tenderness. Okay, now make sure you ask a question that's very important. Is it planned, the pregnancy or not? So in history, I need to ask, is it planned or not? Why? Because if I'm suspecting ectopic, what is the fate of the pregnancy? The pregnancy will end if I'm suspecting ectopic. So it is either a breaking bad news, because if she's not expecting it, if it was planned, but if it was not planned and maybe she's not gonna be happy with the pregnancy, it's not gonna be as bad. I'm not gonna be happy, but it's not gonna be as bad as if it's expected or planned. So be careful in the history, ask about, is it planned? Was it planned, the pregnancy? So now we're gonna say provisional diagnosis. Unfortunately, the fetus or the developing embryo cannot continue. Why, doctor? Because the pregnancy is in the tube rather than the womb. So that will lead to life-threatening condition for you, and the pregnancy cannot continue. Okay, so now management. Number 1, admit, very important. Admit, very important. There are obs and gynae, you don't need to refer. Admit. Number 2, talk to senior. Number 3, investigations. Investigations are very, 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 very important. As we know, blood, urine, stool image. Blood is a must. Okay, HCG, the pregnancy hormone. HCG, pregnancy hormone. Pregnancy hormone is very important in the blood, plus everything else, infection marker, full blood count, in order to know if there's anemia or not. Okay, urine, yes, you need to urine. Okay, and urine again for diagnostic, urine for diagnostic, and pregnancy test. But it was done in the question that pregnancy test was done, urine test, so you don't need to do it. Stool, no need for stool, and then ultrasound, you need a scan. Ultrasound scan. Okay. So blood test, mainly HCG, and ultrasound scan. And be careful because in the management, don't forget that step 4 is symptomatic. Why did she come to the hospital with pain? So painkiller, don't forget painkiller. And management is simply monitoring the HCG. We will monitor the HCG, the pregnancy hormone. If it's decreasing, do nothing. If it's increasing, we'll give her medication called the methotrexate. So if it's increasing, we'll give her medication called the methotrexate. And the methotrexate that will be given, okay, it will be given to stop the pregnancy from growing. And then again, monitor the HCG. After the methotrexate, if it's still increasing, then surgery, keyhole versus open surgery. If the pregnancy hormone after the methotrexate is decreasing, again, wait and watch. Okay, so That's it. And the methotrexate is single injection into the buttocks. All right. Then she may refuse admission. If she refuses admission, simply ask her why are you refusing admission, and then if she's having a concern, address the concern and carry on and say to her, you need to be admitted because, or you should stay admitted because of life-threatening condition. All right, that's it. Okay. All right. Now, I will come to the second case, which is preeclampsia. So the second case is preeclampsia, okay, because it's one of the most important cases. So preeclampsia, page 34. All right. So preeclampsia. I'll read the question to you. You are an FY2 doctor in Obs and Gyne. Layla, 29 years old, who is 36 weeks pregnant, has been referred to the hospital. The midwife has noticed two things. Blood pressure is high, 160/110, and protein in her urine, and she said that she must be reviewed by a doctor. So blood pressure is high. That's it. And she's 36 weeks pregnant, all right? So now, I will go through the same structure and I will show you how we tackle it. P1, P2, P3, P4, مفتوزة. All right. Be careful because she is 36 weeks pregnant. She is 36 weeks pregnant. So be careful because you're gonna show her rapport pregnancy. Number one. Number two, she's been referred to you because of the blood pressure is on the higher side. So what is the meaning of rapport pregnancy? I can see from my note. First of all, I am Dr. Fatih Al-Bab, one of the doctors here. Can you please confirm your full name and date of birth? Okay. I can see from my note that you presented with or for the follow-up of your pregnancy. Yes. Can you please tell me how many weeks you are? 36 weeks, doctor. How do you feel about it? Doctor, I'm happy. I can do, oh, congratulations. So, it's not Breaking Bad news station, all right? Then you will move, you will say to her, well, the reason why, or do you know the reason why you've been referred to me? No, doctor, well, the nurse or the midwife has realized or has found that your blood pressure is quite high, okay? 160/110. And also she found that you have protein in your urine. Have you been told about it? No, doctor, all right? For that, I would like to have chat in order to make sure that everything is okay. Then, what is the presenting complaint here? Blood pressure. So P1 is high blood pressure. That's it. Station is finished. So P1 is high blood pressure. P1 is high blood pressure. So you will explore. You will say to her, or you need to establish this blood pressure. Is it high from before the pregnancy? Because if so, it will be called the essential hypertension. Or is it high, or have you been told that it's high with the start of the pregnancy? If so, it's gestational. Or if it's high after 20 weeks, if so, it will be called preeclampsia. Our case is preeclampsia, so you need to actually establish that the blood pressure started to be high only after the 20 weeks of pregnancy. So please ask about the time she developed high blood pressure. Also ask about the symptoms of the blood pressure, risk factors for blood pressure, complications for blood pressure. Don't forget, like any case, we need symptoms, risk factor, complication. Ask about the symptoms: headache, blurred vision, chest pain, shortness of breath. Ask about the risk factors, or dizziness as well. Ask about the risk factor. Risk factor for any blood pressure, it will be lifestyle. So in the risk factor, I will need to ask about her diet. I will need to ask about smoking. alcohol, which basically comes at P3. So don't forget that I told you the structure is mine, but I can bring things early. So I will ask about the risk factor, okay? Smoking, alcohol, diet, and also risk factor for preeclampsia during pregnancy can be any medical condition, can be any of the medical condition, can be the fact that she might be having twin, can lead to high blood pressure. Anyway, complication can be if she's old age, if she's getting pregnant later on in her 30s, okay? So complication, ask about the complication of the preeclampsia, which is eclampsia. Any fit, okay? Have you had any fits? And be careful because she's 36 weeks old. You must ask her, have you been appreciating the baby's movement? If she said yes, any changes? Very important question, baby's movement and any changes. That's basically my presenting complaint, blood pressure, establish which weeks, establish symptoms, risk factor, complications, and then I will go for P2, P3, P4 maftosa, but here it's a quick history because P2, have you had this before? I've asked already, and medical condition, but medical conditions here is very important. The medical conditions I have mentioned in day one, which is high blood pressure, before diabetes, cholesterol, and all these conditions. All right, and then maftosa is not really important here, but you need family history, allergy, medication, and that's it. You don't need travel, you don't need occupation, you don't need social, okay? And P4 already, in the P4, you're not gonna need all P4 because she's pregnant already. You don't need to ask about period. You don't need to ask about pregnancy. She's pregnant, so it's not needed yet, okay? So now let's go quickly through the preeclampsia. So the symptoms, I'm gonna go quickly through the positives, yeah? The symptoms will be high blood pressure, headache, vision problem, blurred vision, chest pain, nausea, vomiting, okay? These are the symptoms of the high blood pressure. So you'll ask about it, okay? Ask about the red flags, convulsions or fits, okay? You can ask even about edema hand and feet. So headache, blurred vision, chest pain, shortness of breath, tummy pain, nausea, and swelling hand and feet, okay? Very important, edema or swelling hand and feet. Red flags is convulsion, and that's it. These are the symptoms, and as I mentioned to you, the causes or the risk factor for that will be in DESA, diet, smoking, alcohol as a DESA, and the complication is convulsion or fits, and that's it, okay? This is the case. Now, preeclampsia, when you give her provisional diagnosis, what is preeclampsia? It is high blood pressure after 20 weeks of pregnancy. Then management, number one, she will need to be kept in the hospital. She will need to be admitted. Blood pressure will be monitored. So admission, monitoring the blood pressure, senior. So follow the steps: admit, senior, investigations, regular urine sample, regular blood tests. I will always do blood test, the kidney function test, because blood pressure affects the kidney, okay? Ultrasound scan, and I will check the baby's heart sound, and monitor the baby's heart rate, very important, okay? And monitoring the blood pressure. All right, then she will be giving a medication, labetalol. To decrease the blood pressure. So medication to decrease the blood pressure. Delivery for the baby. If she's 36 weeks, I will wait till 37 weeks. If she is 36, so you will have to wait till 37 and see. All right. So basically, if the condition is more severe before 37 weeks, then delivery will be early. However, if the blood pressure is controlled, you can wait till 37, you can wait till 38, okay? So, doctor, am I gonna have natural, am I gonna have normal labor or cesarean? No, she will be started normally, but we might induce her at 37 or 38 weeks, okay? So the management, simply admit, senior, investigations, blood, urine, ultrasound. I will check the baby's heart, baby's heartbeat, very important. Then I will give her number 4, step 4, symptomatic, labetalol, and monitor. If the blood pressure is not going down, if it's uncontrolled, if it's increasing, labor early. However, it's controlled, I will wait till 37 or 38 weeks and then deliver. The delivery, it's gonna be induced labor. However, there's a chance also of having cesarean, okay? And that's it. All right. Next case is bacterial vaginosis, okay? Again, my structure stays the same, P1, P2, P3, P4, maftosa, okay? As I told you, P3 is DESA, plus or minus sexual and IV. As I told you, P4 is the period, pregnancy, pap smear pills. As we know, presenting complaint what the patient came with. P2, we know P2, past history, complaint, past medical condition, and maftosa. Okay, now, bacterial vaginosis. Bacterial vaginosis, the presenting complaint will be discharge. Don't forget, discharge. So be careful, because if the patient is coming with discharge, I said to you, what are we going to use? If the presenting complaint coming with discharge, tell me more, and then track. Use track. What is track? Timing, relation, or trauma. Is it related to anything specific in particular? Amount, color, and nature, and if there's any blood in it, okay? All right. I said to you the sexual and the P4 must. So, you are an FY2 doctor in the GP clinic, Isabel Clark, 34 years old. And be careful, because whenever there is a case of discharge, always don't forget sexual history, very important, yeah, sexual history. And always don't forget to ask about STI screening. Don't forget in these cases of any discharge to ask about STI screening. Have you had STI screening, HIV screening test, okay? So you are an F1 doctor in the GP clinic, Isabel Clark, 34 years old, presented a week ago with vaginal discharge. Swab was taken and it came positive for bacterial vaginosis. So is that confirmed? Is that confirmed blood test, or is it new, Dr. Mo? It is confirmed. Swab was taken and it shows bacterial vaginosis. Do you need to take history? No. Which structure do you follow, Dr. Mo? Test result. Go to day 1, test result structure. So I will tell her, what brought you for this test from the first place? She will say, doctor, I had discharge. Explore the discharge. Any differential, Dr. Mo? No. Ask about the risk factors, complications, then explain the result, then manage. So this is my structure. So my structure is, the first part is what brought you to have this test from the first place. Easy. She will tell you, doctor, I had discharge. Explore about it. Explore about any other symptoms away from the discharge. No differential, because it is confirmed. Swab was taken. Ask about any risk factors. Ask about any complication. Then move on to the second part, which is explaining about the result. Explaining about the swab result. Then the third part is management. However, if the case is a patient who's coming with discharge, swab was not taken, swab was not done, no diagnosis, that's medicine, then I will use this structure. Okay, so here, what are the symptoms, positive symptoms for bacterial vaginosis? So unusual vaginal discharge, fishy smell, strong fishy smell, particularly after sex. Okay, all right. Then a change to the color and the consistency of your discharge, such as grayish, whitish, okay, discharge. So you always, any female have discharge normally. So always ask her any unusual discharge, okay? Risk factors for bacterial vaginosis is basically the risk factors, sexual activity. So ask all the time about sexual history, The patient who, women who have not had sex can also get PV. That doesn't mean that it only comes to female who have sex, but sexual history is a factor. But it can come to patients who have not had sex, okay? Number 2, change partner, change partners, change partners. Number 3, IUD. Number 4, perfumed product. So as I told you, not only we are trying to diagnose, but also are trying to find out the reason why she's having it, to advise her about it. Okay? So again, bacterial vaginosis. Discharge that's fishy smell, strong fishy smell. Okay? Strong fishy smell. And by that, I told you it can come either confirmed after a swab, which I will follow one structure, which is blood test result, or medicine, which is I'm gonna deal with it as new station of discharge exploring. Risk factors must be asked. Sexual activity, change of partners, IUD, perfumed product. Okay, let's agree on this. Bacterial vaginosis is not an STI. Okay, even though it's triggered by sex, but it's not an STI. Okay, so if she asked you, it's not an STI. All right. On examination, you will verbalize examination. No problem. Okay. If the case is new, when we talk about management, if the case is new, which means it's a medicine, not confirmed, be careful, because you will start with blood, urine, swab. But if the swab was taken and confirmed, you don't need investigations. You just manage that away, okay? This case, it is confirmed with a swab. However, if it's not confirmed with a swab, what are the investigations? If the case is newly charged, swab, blood, urine, okay? But the case is confirmed. So basically, in this case, I will say senior, symptomatic, general advice. Symptomatic, which is bacterial vaginosis, is usually treated with antibiotics, tablets, or gel, or cream, okay? So if you have, again, bacterial vaginosis, the treatment, antibiotics, any form of antibiotics, tablet, gel, or cream, okay? But the advice is more important. What do you mean the advice? Advice here, do and don't. Do, use water and plain soap, no perfumed stuff, no perfumed product, okay? Have a shower instead of a bath. Bath with perfume product is a risk factor for bacterial vaginosis. Things that you shouldn't do. Do not use vaginal deodorant, vaginal douches, vaginal washes, okay? Do not put any antiseptic liquid in the bath. Actually, having a bubble bath is a risk factor. Shampoo in the bubble bath, again, is a risk factor. Perfumed soap is a risk factor. Smoking is a risk factor. So do and don't. Treatment, antibiotic. Okay. Next case is PID. Let's discuss gonorrhea. First. Gonorrhea. Again, gonorrhea, I have two scenarios. Okay? And by the way, with bacterial vaginosis, you should know that in the question, it will tell you that a swab was taken and it was positive for Gardnerella, okay? Or bacterial vaginosis, all right? So now, gonorrhea. Again, we have two cases of gonorrhea. Either a gonorrhea confirmed, which means a female, 25 years old, presented to the GOM clinic, which is gynecology clinic, and was discharged. A swab was taken, showed gonorrhea. Talk to her, address her concern. Exactly. It is a case of test result. So is it confirmed? Yes. Is it diagnosed? Diagnosed. Swab was taken, showed gonorrhea. So what's the approach? Medicine or test result? Test result. Do you need differentials? No. You need only risk factors. Why? I need the risk factor in case the patient asks me, why did I have it? So I have an answer for it. I need the risk factor, the cause for gonorrhea. And we know that it's STI, so the cause is sex, unprotected sex, sexual partner. As well as complication. What is the complication for gonorrhea? PID. 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 So it can come as follow-up or it can come as medicine. What do I mean by medicine? Newly diagnosed, newly station discharge. In that case, if the case is coming diagnosed and swab was taken, do you want to do swab? No. Do you want to do blood? No. Do you want to do urine? No. But if the case is discharge, I don't know. So I will do swab, blood, urine. And if the case is medicine, I will go with the discharge, exploring the discharge, differentials, P2, P3, but P3 no DESA, just sexual history and the IV, and P4. But if the case is follow-up, you don't need all of this, okay? So this case is, you are an F1 doctor in the GUM clinic, Mrs. Maria, 24 years old, came with discharge. Swab was taking, showed gonorrhea, talk to her. The only difference, bacteriovaginosis, if she said to you, is it STI? It's not, but it is STI. Okay? Okay, so symptoms of gonorrhea, unusual, don't say discharge, don't say abnormal. Unusual vaginal discharge, which will be greenish, yellowish, sometimes burning sensation while passing urine, pain, burning sensation while passing urine, sometimes lower abdominal pain, bleeding in between periods. These are the symptoms. Okay, what is the risk factor? Sex. Sexual history must be taken, and sexual partner. For how long, Dr. Mo? For how long should we go? We should go up to 6 months prior to the unprotected sex that she had. Because if the lady had practiced sex using condoms, the risk is not there. The risk is there with unprotected sex. So always ask about unprotected sex as a risk factor. What is the second risk factor is sexual toys. Sexual toys, because if she is using toys that's been used on someone else and it has the bacteria, it is a risk factor, okay? So these are the risk factor. Complication, PID. So don't forget to ask about symptoms, number 2, risk factors, number 3, complication. Risk factors, unprotected sex, and in that case you will ask about sexual history in details. Are you sexually active? Do you practice safe sex? Do you have a stable partner? And in this case, you will be practicing safe sex, unprotected sex, okay? And don't forget to ask about sexual toys. How to ask about sexual toys? Use a third party. Use a third person. Use a third party. Sometimes, some females tend to use some toys to stimulate themselves. Do you experience the same thing? Okay? And always signpost. I'd like to ask some questions that may sound intrusive, but bear with me, okay? Management of gonorrhea. Again, you are in the GUM clinic, so senior, treatment, symptomatic, go back to symptomatic treatment. Do you need investigation? Because there are investigations, but do you need? No. If the case is new, yes, I do. Swab, blood, urine, and then you will treat gonorrhea. But if the case is diagnosed, start giving medication right away. Antibiotics, okay? It's gonna be antibiotic injection followed by antibiotic tablet. So 1 injection in the bottle followed by 1 tablet, okay? Make sure you advise her during treatment not to have sex. So she should not practice sex, not even safe sex. No, it's better not to even have sex, okay? So it's better not to have sex. Always in these cases, ask about the partner as a risk factor. Always ask about the partner because the partner is a risk factor. Always ask about the partner. Always ask if the partner has symptoms like pain. Always. And in management, after giving her the antibiotics, and after giving her 1 injection, and after telling her that she will as well need 1 tablet, you don't need to mention the names, okay? However, you need to talk about the partner, that you need to bring your partner to be treated. It's a risk factor. She will refuse, ask her why, address her concern, and you can offer her partner notification program. But it's very important for the partner to be treated, even if there is no symptoms, because sometimes it's asymptomatic. Advice, not to have sex during the treatment, and after that, advise her to have protected sex. Sexual partner must be treated, and you must ask about the partner for how long? 6 months, not before that, okay? And always advise her, always advise her to have STI screening on the change of any partner, okay? And always advise her to have STI screening on the change of a new partner. The next case is HIV. HIV. You are an FY2 doctor in the GP clinic. John Bernard, 40 years old, presented with a generalized lymphadenopathy 2 weeks ago. Blood tests were done 2 weeks ago. And HIV screening was done and it was positive. Talk to the patient, take history, and explain the result. This case is a sort of breaking bad news case. Okay, a patient presented with lymphadenopathy and they took a screening and it showed HIV. Okay, so be careful because it is diagnosed or not, it is diagnosed. Okay, again, I can have 2 scenarios. I can have a patient who's coming with lymphadenopathy, but no tests were done, no investigations, nothing. In that case, you will do investigations, which will be medicine case, lymphadenopathy. And I can have a patient who's coming lymphadenopathy and diagnosed case of HIV. In that case, you don't need differentials. You just need, again, risk factors, complications. Why? Because it's diagnosed, HIV diagnosed. So he will tell you, why am I having it? So you need to ask about the risk factor. And again, the risk factor for HIV is, it is sexually transmitted infection, so sexual history, unprotected sex. And in this case, HIV, you ask about anal sex. IV drug abuse is one of the risk factors. Recent blood transfusion is one of the risk factors. Recent surgery, one of the risk factors. Travel history, so 5 things. Travel history, recent surgery, recent blood transfusion, IV drug abuse, sexual history. You must be asked here as a risk factor. Okay? So in this case, what are the symptoms? Oh, and if the case is diagnosed, no history. Just symptoms, risk factor, complication. If the case is not diagnosed, history. Okay, most common symptoms are temperature raised, sore throat, body rash. Other symptoms, he's tired, joint pain. But as I mentioned to you, this case came with generalized lymphadenopathy. Again, weight loss, night sweat, weight loss, chronic diarrhea. All these are symptoms of HIV. Don't forget to ask about the risk factors. Yes, 5. Management of HIV case. Okay, management. These cases, it will be a specialist HIV clinic. But be careful because if the case is diagnosed and he doesn't know, a sort of breaking bad news. Okay, so be soft about it. If the patient said to you, doctor, will I die? Tell him HIV nowadays is getting treated like any medical condition, any chronic medical condition like diabetes, like high blood pressure. You get medication for it, and as long as you are compliant with the medication, it will be under control. Okay, so yes, you can reassure. Because HIV nowadays, yes, they take tablet, it's a chronic, and it can be controlled, 1 tablet a day. So always reassure, okay? So, yes, specialist HIV clinic. If there is no investigations done, you will do investigations, bloods, full STI screen. But if the STI screen was done, HIV screen was done, it's done. 2 important blood tests, HIV viral load and CD4 lymphocyte cell count. HIV viral load, it's very important. Monitoring the amount of HIV virus in the blood, CD4 lymphocyte count, okay? Medication, 1 tablet a day. Antiretroviral drugs, 1 tablet a day. It will be given, the viral load will be low, then it is controlled that way, okay? Very important to talk about lifestyle, very important to talk about safe sex, condom, very important to talk about the partner. If the partner has any symptoms, very important to talk about that the partner needs to come and get investigations and managed. Very important, social or psychological support is very important. Informing the partner, the patient will refuse, ask why, he will give you a reason, address the concern for which he is refusing, and always tell him the risks of not telling the partner, and the partner needs to be told, and also people who are at risk. If this patient is going to surgery, he will the surgeons and the team will be told. If this patient is working in the military, again, so people at risk, so armed forces, military, all right? Okay, so now always advise them to basically on the all the time when we give the drug, the antiretroviral medication, okay, it is always you will check the viral load, and when it's very low, it's called undetectable. So always talk about the partner, always talk that the partner is to be managed, investigation for the partner, and safe sex, and always advise to inform if it's a military, if it's people at risk, if he's going for surgery, okay? And obviously not to do blood transfusion, okay? Okay. Syphilis, again, one of the sexual transmitted infection. Syphilis, the station is you are referred to doctor in the GP clinic. Jack, 24 years old, has come with a lesion in the skin, in his private part, ulcer, and basically talk to him as his concern. Again, what is the presenting complaint? Ulcer in his private part. So again, that will go quite with dermatology stations. When we have any lesion in the skin, we ask about since when. So what is the presenting complaint? Ulcer, lesion in the skin. Since when? How did it start? Site, change in site, it's the penis, for example. Anywhere else. Size, any change in size. Shape, any change in shape. Is it itchy? Any bleeding? Any discharge? These are questions for any lesion. So any lesion, since when? How did it start? Site, it's the penis. Anywhere else. Size, change in size. Color, any change in color. Is it itchy? Is it painful? Any bleeding? Any discharge? Any fever? Okay? With any ulcer. In this case, it will be small, painless ulcer. Small, single, painless ulcer. Okay? It's called chunker. So small, painless, single ulcer. All right. So it will be on the penis or vagina or around the anus. Okay, the genitals. All right. That's it. Sometimes they come with lymphadenopathy, swollen glands, neck, under the armpits, and groin. On examination, we'll be giving a picture. On examination, we'll be giving a picture of the ulcer. Management of syphilis, again, referral to the gum clinic. Step 2, senior. Step 3, because this case is not diagnosed. As I told you, the presenting complaint is ulcer. So not diagnosed. So investigations. And be careful, because whenever the patient has ulcer, I follow the same instruction. P1 is ulcer. We explore the presenting complaint. And because it's not diagnosed, all the time in syphilis, ask about sexual history, ask about STI screening, ask about, because it's a male, yeah? Ask about STI screening, ask about sexual history, ask flows. Okay? Now, investigations, blood test, swab from the ulcer, test for other STI. So swab, blood, test for other STI. So don't forget bloods, urine, swab, test for other STI, okay? Now, treatment, short course of antibiotics. Again, short course of antibiotic. And it's very important to ask about the partner. If the partner is having any symptoms, very important to ask about the partner, okay? And it's very important to advise about, again, safe sex, okay? Syphilis that has lasted less than 2 years is usually treated with penicillin into your buttocks, okay? Or 10 to 14 days course antibiotic tablets, penicillin again, yeah? So Syphilis that has lasted more than 2 years, usually treated with 3 penicillin injection into your buttocks or 28 days course of antibiotics. So, depending on the time, if the syphilis is more than 2 years, the course is longer than if the syphilis is less than 2 years, right? So, follow-up is very important. Blood test follow-up is very important. Side effect of the treatment is very important. So, flu-like symptoms and the advice, as I told you, avoid any kind of sexual activity or close sexual contact with another person for at least 2 weeks. Avoid. Guys, avoid. Tell the partner, inform the partner. The partner needs to come for investigations. So all the time, whenever you have STI, talk about the partner's symptoms. Talk about if the partner has any symptoms. Talk about the need for the partner to come for investigations all the time. And all the time, avoid sex until they are treated, and after that, safe sex. All right? So, okay, we need now to discuss pelvic inflammatory disease. Pelvic inflammatory disease, PID. Okay, there is a doubt, and there is sometimes people ask question about if the case is gonorrhea, do I have to tell my partner? You advise me to tell the partner. You speak about risk and benefit, but you don't have to. But if the case is HIV, you have to. Okay, obligatory. So first of all, I give you some time to think about the partner notification program. We tell the partner, definitely, yeah. Then the third case, or the case after that, is PID. PID, pelvic inflammatory disease. PID, pelvic inflammatory disease. Again, it can come either follow-up, a patient who's diagnosed PID and coming for follow-up, or it can come as medicine, a patient is coming with a discharge, chronic pain. So either or. What do you mean, doctor? Either new station of presenting complaint, chronic tummy pain or discharge, or follow-up station, a patient who had previously tummy pain and discharge, came, investigation was done, and she is diagnosed PID, and she is under the management of antibiotic, and she's under follow-up now. So in this case, I will use that follow-up, what brought you from the first place, symptoms, risk factors, complication, move on. So in this case, you don't need differential. But in this case, if it's a new station, if it's a station that's not diagnosed, you need differential. So you are an F1 doctor in the Obs and Gynae department. Tanya Morris, 30 years old, presented with right lower abdominal pain. Talk to her, address her concern. Okay, number one, what is the symptoms of PID? From the name, PID. What is the first letter? P. So pain during everything. Chronic tummy pain during sex, pain during period, pain during passing urine. It is chronic pain. So symptoms, pain. So when the patient comes to you, new station pain, explore the pain Socrates. Apart from the pain, anything else, she will give you discharge, explore track. You know what I'm talking about. Pain Socrates, discharge track, timing, relation, amount, color. So pain. So symptoms of PID, number one, pain, lower abdominal pain. 2, pain during sex. 3, pain while passing urine. 4, pain during period, and then bleeding in between period, painful period, heavy period, all this PID. Okay? Again, am I here to diagnose only or to know about risk factors? Risk factor. So if the case is pain, abdominal pain, after you ask about the other symptoms, what are my differentials? If it's a new case, no follow-up. My differential again, tummy pain, vomiting, diarrhea, constipation, fever, fair enough. Okay? But because PID, don't forget, sexual history, don't forget P4. That's it. So PID, presenting complaint is P, pain during everything. explore it. Apart from the pain, anything else? No, doctor. Risk factors we need. Risk factors we need. Don't forget pain. So ask about differential, vomiting, diarrhea, constipation, fever. Okay? Then sexual history is a must. P4 is a must. What is P4? Period, pregnancy, pap smear, pill. Okay? We spoke about the symptoms. What are the risk factors for PID? What are the risk factors for PID? The first risk factor for PID is previous STI. So if the patient has had STI before and it's not managed well, it can complicate onto PID. So always ask about previous STI. The second is IUD. The third, procedures. Like if she had an abortion, she can have PID. So procedure, ask her, have you had any procedure to the front passage? Previous STI, previous STI, previous STI, previous STI, and untreated previous STI, yeah? So IUD is one of the risk factors. So 3 things. You must verbalize examination. And always ask about sexual history, all the time. Sexual history. And be careful because the risk factor, not all of it because of STI, we said some of it. So STI not treated properly can be a risk factor for PID. However, other causes, IUD, procedure through the front passage, instrumentation, anything that causes trauma. So if she said to you, doctor, is it because of my partner is cheating on me? It's not for me to answer. However, PID only 25% of the cases can be caused by untreated STI. However, there are other causes like previous procedure, instrumentation, and this and that. Complication of PID, because I said to you, with any case, not only you need the symptoms, but also you need the risk factors and the complication. Complication of PID can lead to infertility if it's not treated, can lead to miscarriage if it's not treated, can lead to chronic abdominal pain if it's not treated, can lead to abscess. Okay? So, can lead to infertility, miscarriage, can lead to abscess, can lead to chronic pain. So these are the complications. So management of PID, again, talk to senior, yes. Investigation, as if it's a new case. Swab, blood, urine, swab, transvaginal ultrasound scan. So, talk to senior, yes. Investigations, yes. What are the investigations? Investigations are bloods, urine, and with urine dipstick, urine culture, blood, all the blood. You need STI screening, you need ultrasound, transvaginal ultrasound. Now, symptomatic treatment, yes, step 4. She's in pain, painkiller. She needs antibiotic. But the antibiotic here, unlike the gonorrhea was 1 injection, 1 tablet. Here, she will need 2 weeks of antibiotics. 14 days. She will need antibiotics for 14 days, okay? And in severe cases, she will be on a drip, intravenous. So painkiller, antibiotic for 14 days. She will need follow-up. Yes, she will need follow-up. Follow-up, yes. She will need follow-up, yes, twice. One after 3 days and the second one after 2 weeks, okay? And you need to talk about the risk factors. So if this lady has IUD, it needs to be removed. Risk factors, sexual partner, the partner must come, checked, investigation, treated, okay? And the sexual partner, 6 months only, with a period of 6 months only. And again, like any STI, avoid having sex for 2 weeks until she is treated. And after that, condoms, protected sex, and after that, condoms. And I said to you, follow up twice, at 3 days and at the end of the course of antibiotics, okay? And all the time, advise STI screening or change a partner. All the time, avoid sex during treatment all the time, practice safe sex all the time. Okay. So safety netting, always, if there is an IUD, it will be taken off, and you will offer her other form of contraception, yeah? Other form of contraception. And always safety netting for complications, infertility, as we said, abscess, okay? All right. Ectopic, PID, vaginosis, okay. Okay. So now we need the premature ovarian insufficiency, and we need polycystic ovarian syndrome. 19. Okay. Premature ovarian insufficiency. Premature ovarian insufficiency. Okay. Station. You are an FY2 doctor in the obstetric department, gynecology department. Mrs. Maria Taylor, 26 years old, presented a week ago with amenorrhea. So, amenorrhea a week ago. Blood tests were done, showed estrogen low, FSH to LH high. Your senior believed that she has premature ovarian insufficiency. Is it diagnosed or not? It is diagnosed. Medicine or blood result, test result. Any history? No. Just symptoms, risk factor, complication. Any differentials? No. Not medicine structure, counseling structure. So now we need to talk about the symptoms. The symptoms: amenorrhea or irregularity. That's as primary. It can cause primary or secondary amenorrhea. Okay, and hot flushes, night sweats, vaginal dryness, discomfort during sex, difficulty sleeping, reduced sexual drive, libido, okay? Problems with memory and concentration, okay? So that's it. These are the symptoms, all right? Sometimes they come to you with mood swings. So this is premature ovarian insufficiency. Okay, these are the symptoms. These are the symptoms of the premature ovarian insufficiency. So causes, family history is a very important cause. Sometimes autoimmune, smoking, sometimes surgery, past history of surgery, surgical removal of the ovaries and hysterectomy. These are all risk factors for premature ovarian insufficiency, okay? The case is diagnosed, no need for differential. Now, management, simply if the case is diagnosed, you don't need investigation. But if the case is not diagnosed, you need investigations, okay? So if the case is not diagnosed, senior, investigations what? Blood test, hormones, you will check the prolactin level, screening for autoimmune disease, adrenal antibodies, okay? Image, yes, image. I will do DEXA scan, transvaginal ultrasound, okay? Now, the management in these cases is simply replacement and lifestyle. So replacement and lifestyle. So these cases, replacement and lifestyle. So I will encourage them, DSM, diet, exercise, stop smoking, okay, decrease alcohol, lifestyle, general lifestyle, be careful, general lifestyle. And now, because they are at risk of osteoporosis and all kinds of stuff, replacement, HRT, combined oral contraceptive pills, vitamin D, calcium, and that's it, okay? So this is the management that you will do. So as an FY2 doctor, your management is lifestyle, advise her about diet, exercise, quit smoking, decrease alcohol, always all the time talk about supplement. You will give her HRT because this is like early menopause. You will give her HRT, hormone replacement therapy. You will give her other replacement like calcium, vitamins, and always when you talk about HRT, speak about the medication itself, dose, form, side effect, contraindication. Okay? Now, okay, that's it. There are support groups, so you can talk about support groups, okay? Counseling, all right? So many support groups in UK. So polycystic ovary. So polycystic ovary syndrome, PCOS. Again, this case is diagnosed. Diagnosed means it's a case of follow-up. Follow-up means it's a case of what brought you for this test, ask about the symptoms, risk factors, complications. Move on to the second part, is explaining the result management. Yeah, you are now first doctor in the GP clinic. Sandra Scott, 29 years old, presented a week ago with acne, irregular period. Blood tests were done, showed LH high, LH to FSH ratio 3:1, BMI is high, and FSH is normal, pregnancy test is negative. By the way, this case, the polycystic ovary, is a case of lifestyle. Nothing but lifestyle. What do you mean, Dr. Mo? Nothing but managing the lifestyle. That's it. Just to cut the story short. The case is diagnosed, yes. Blood tests are there. So in this case, it's just what brought you for the test from the first place. She will give you some symptoms. Explore the symptoms. After you explore the symptoms, ask about the risk factors and complication, and that's it. Move on to the second part, explaining the result, then management. Management is DESA, okay? DESA is the lifestyle. So what are the symptoms of the PCOS? So what brought you for this test from the first place? She will give you some symptoms, explore them. What are the symptoms? Irregular period, sometimes no period at all. Difficulty in conceiving, difficulty in getting pregnant, excessive hair growth, hirsutism, weight gain, thinning of her hair, oily skin, acne. On examination, observation and BMI. BMI will be high. That's it. Managing the PCOS. Management. As I told you, this is a case of lifestyle as your job. However, it will need referral. Refer where? Specialist, gynecologist or endocrinologist. So it's a case of referral. So what you will do is DESA, and then you will refer her to gynecologist or endocrinologist. Okay? Talk to senior, run investigations. If the investigations were not done, if it's a new case, okay, medicine case. But if investigations were done, you don't need to. But if there is no investigations, you need blood test, screen for diabetes, high cholesterol, because it's, again, they come together. You need ultrasound scan to check the ovaries. Sometimes when you check the ovaries, you see both ovaries for cysts. That's if it's not done. If it's done, it's done. Lifestyle, so that's what you need now. DESA. Talk about diet, healthy diet. Talk about exercise. She needs to lose weight. Balanced diet. Advise her about diet. Stop smoking. Decrease the amount of alcohol. So that's your job is DESA. Okay? Can she be given medications? Yes. Plenty of medications. Mainly contraceptive pills can be given to her, okay? Sometimes they do some methods, laser removal of the facial hair, if it's affecting hair which will be and bothering hair, so laser removal, okay? Follow-up is needed, as I told you, very important in these cases, is lifestyle, which is your job, okay? So, guys, I think that's it. Thank you very much, and we're gonna be having a separate lecture about the contraceptive methods and emergency contraception, and the mother who wants you to tell her if her daughter came on or not. Okay? Thank you very much.